some of my colleagues send me data of their COVID patients they're treating in some of the big hospitals. Maybe the sample size is limited, but when I am doing logistic regression against variables um, giving patients steroids, anticoagulants, even tocilizumab, and against survival or people requiring ventilation, I notice no significant association. It seems like up till now, the data I have evaluated, again, it's not published data, it's just my observations in my own setup, that the only thing which was predicting death was age and comorbidities. And so are these anticoagulants, steroids, and all these other drugs which we are using, are they really effective?
Excellent question. And I've noticed the same thing as well. It seems like nothing we do in the hospital is beneficial. And it's just some people are going to get better no matter what you do, and some people are not going to get better no matter what you do. A couple of caveats on that, though. Very early on, we were anticoagulating everybody coming into the hospital, everybody. We were giving them what in our country is called Lovenox, which is enoxaparin, which is a low molecular weight heparin. Initially, that was recommended because it was easier and the nurses didn't have to interact with the patients more. And that was a concern at the very beginning. But you and I know that nurses are going into that room far more often than just twice a day. And so the other option was a heparin, unfractionated heparin drip to give as well. Well, it was just in December of this last year that some papers came out that was based on a very, very large international, in fact, it was 3 different international groups that combined their data. So very, very robust data. And what it showed was something very, very interesting, was that anticoagulation in the intensive care unit. So if a patient was admitted from the emergency room to the intensive care unit for COVID-19, that anticoagulation did not benefit in any way. And then in fact, it may have made it worse. And I'll have to tell you that I saw that as a critical care doctor. I don't think it helped. And I saw a number of patients that developed very severe intramuscular hematomas. We had one patient that had a compartment syndrome in his arm because of a hematoma. We had another patient that had a rectus abdominis. That's basically the abdominal muscle hematoma that ruptured internally into the peritoneum. It was a very severe hypovolemic shock. The same group that said that, though, however, about a month later in January of this year, released data that showed that anticoagulation in patients with COVID-19, not admitted to the intensive care unit, but admitted to the regular floor, benefited from anticoagulation. I just have to say that to me, it seems as though what you're doing there is you're selecting out patients that have been caught earlier, right? So we all think that patients in the emergency room are coming in at the same point of their disease, which is clearly not the case when you start to think about it. The people that are coming in later are usually being admitted to the intensive care unit, and the people that are coming in earlier are being admitted to the floor. And so again, it tells me that unfortunately, the therapeutics that we're trying to work on and give to patients in the hospital, it may be too late. And I think with the exception of steroids, which clearly based on the UK recovery trial, show that it works. It's kind of like a final shot in the dark type of thing. But in terms of remdesivir, in terms of tocilizumab, in terms of anticoagulation, I think what we have done, and it's understandable, we have very limited resources. We have limited amounts of these medications. And so what we decide to do from a human standpoint is say, we have limited resources. Let's use these on the people that are the sickest and that are the fewest amount, so that we have enough resources to carry people through. And the problem, I believe, is that these tools may be more beneficial if they're given earlier, but because there's so many of these people, it's difficult to determine who should get it. Now, there has been some inroads there with the monoclonal antibodies. And at least in our country, we've had a situation where if you were sick and you had COVID-19 and you had a number of comorbidities like hypertension, diabetes, we could talk about those things too. Then you could go to the emergency room. They would give you the infusion of the monoclonal antibody and then send you home, hoping that that would prevent you from coming back a week later to have to get admitted to the hospital. But your observations are exactly the same as my observations. And I believe that what we should be focused on, and I'd be willing to even talk about what my thoughts are. You said that you had some philosophers and people in your group, and I love to philosophize. This is a great topic to philosophize about. Is what how do we change our modus operandi? How do we change our paradigms from what we're normally used to dealing with, which is chronic diseases in patients in the hospital going through at a very particular pace, to all of a sudden a massive pandemic where people are dying very quickly. We don't have any proven therapeutics. And so our bar, which is randomized placebo-controlled trials that are peer-reviewed and published and approved, you know, where do we put that? Where's the risk-benefit ratio? I think that's a great topic that we could probably talk about for hours.
Yes. And Sarah has raised her hand again, but I just want to ask one more question. There is a paper I came across, it's from December 2020, I'll share with you, and it talked about, it was from Miami, I think, Florida. And they reported 90% survival rate in patients of COVID who were given stem cell infusions along with the regular therapy, as compared to 42% survival rate in those who were not. And
That's fascinating.
Yeah, and they reported there was no difference in the viral load, but it was the cytokine levels which were affected, and they hypothesized that basically the stem cells were converting into immunomodulating cells, and that's how they were controlling the cytokine storm. That is something I'm really interested in, and I want to actually do this study here as well, because, like, you talked about immunoglobulins that are not available here. If we import them, it takes about 6 weeks, and by that time the patient is not with us anymore. But stem cell therapy is something which people are researching here, and it's available. What do you think about that option, and do you think it should be explored?
I think it should be explored, definitely.